Yeah, so Abhijit is a consultant neurologist, very interested in FND, but also has a long-standing interest and has done and planning lots of research into hypnosis as a treatment for FND. So without further ado, given we're so late, thank you so much for Abhijit for coming at short notice to deliver what will be a fascinating talk. So thank you, Abhijit.
Thank you, Tim. So I'm just starting sharing my screen. Can everyone see my screen?
That's great, Abhijit, yeah.
Okay. So good afternoon, everyone. So before I go ahead, so a few disclaimers. I'm a consultant neurologist at Royal Preston Hospital. I'm also the FND lead for the region, Lancashire and South Cumbria. And few disclaimers. First, this is a project in progress. If you are expecting to see lot of academic stuff, I'm very sorry, the things are in progress. I will show you what we are doing now and what we are planning to do, and that's it. And I'm a hardcore clinician, so we'll talk about clinical problems and how we are trying to sort it out. So with this disclaimer, let's crack on. Because I'm a clinician, I will start with the story of a patient. This is a real patient. Her name is CP, and I saw her just a few weeks later. So she's symptomatic since January 2023. Back in December 2022, she worked in a pub. There was a pub brawl. Someone hit on her head. She fell down. She never lost consciousness, no concussion and other symptoms. She was sent home, and she having the symptoms since first week of January. And she having these events or funny do's where she can hear but cannot speak. And the first time she was brought to A&E, she was referred to what is standard first fit clinic. The first fit clinic, she was seen by a neurologist, and the atypical features were noted, specifically that she can hear people and remember what's happening, and it's more of kind of a depersonalization. And the workup for standard EEG workup was given, EEG. But as she was waiting for the EEG, other things, her life changed. She had to leave her job. Things were getting difficult for her. She had a lot of other symptoms, including intermittent speech problem, fatigue issues, and the events were getting longer and more frequent. And she was going up to A&E multiple times. Again, she was seen by the neurologist back in June. By that time, the workup was possible. This is the normal thing, given the kind of delay that we are having. MRI and EEG was normal. As the events were ongoing, she was advised for long-term EEG. And by that time, because of the event, she cannot drive. She left her job, and she keeps on going to her GP and the A&E. Again, she was seen back in October 2023. She was having these events ongoing. Her sleep-deprived EEG was normal. Now she's visiting the GP once a month, and by this time, she had visited the A&E 8 times. During things worsened, between December 2023 and January, she was admitted in the local hospital. Events were lasting up to 1 hour. She was moved to her parents. And during one of the hospital stay, events were observed, and she was given a diagnosis of non-epileptic attack disorder or functional seizures. At that time, she was referred to our FND clinic. When I saw FND clinic in first week of April, by that time, she has 3 MRIs, 5 CT brains, because every time she was going with some neurological deficit, she was getting a CT brain. She had 3 EEGs. She had visited the A&E 20 times. And she was provided some cognitive behavioral therapy. Nothing is working. She's continuing with the symptoms. So she is a real patient, and this is a real story which we see in our clinic every day. So this is basically what we call in neurology and the big elephant in the room. The elephant always crying for help, but nobody's listening to her. My patient is a verbal words for the patient. There is no place to go and no one to explain. So this is functional neurological disorder for you in a nutshell. There's a physiological disorder of brain activity emerging from an interplay of intrinsic brain mechanisms and life experience, which causes disability in multiple domains and which is sensitive to psychological and physical factors. Now, this is to be real neurological conditions. And we moved up the diagnosis from the previous concept of hysteria, which Hippocrates acquired from the Egyptians. The Egyptians are the first to give the idea of wandering causing all these symptoms because they're more common in females. Then Sharp was the first person who identified them as really functional. There is something there, but not structural, so functional. And Sharp, we'll come back to Sharp later because the first person proposed hypnosis to be used for its treatment. Then the big dichotomy happened, neurology and Psychiatry divided among themselves, and we call it conversion disorder, later dissociative disorder, and it continued till the modern age when we put the name of functional neurological disorder. Now, this is common and important. This is one of our most common cause of referrals, some days up to 30% in our inpatients or outpatient visits, and also commonly seen in acute presentation as a stroke. 10% of hyperacute stroke units are functional by nature. It's very expensive. So total cost is around 3 billion per year, can go up to societal cost around 17 billion per year. And it is equivalent to epilepsy and MS. Now the age range can be pediatric to the elderly 4 to 94. There is striking female preponderance, 60 to 80%. But lower gender difference in children and elderly. It can be seen in male, very well known, and population incidence is 4 to 5. So we estimate that in UK currently there are 100,000 people with functional neurological disorder, similar to the numbers that we see with multiple sclerosis. And 40%, despite all the effort, can go into chronic phase. And this can be a fluctuating course. Some people remain stable for many years, then the symptoms to come back again. And the level of disability, caregiver burden, adverse effects on quality of life are comparable to other major neurological conditions like MS or epilepsy. Misdiagnosis is low and stayed stable between 1 to 4%. Now, this is the bigger picture. Actually, the people come with many symptoms. This is a nice study done by Matt and the team, and you can show this is a overlap with many things, including fatigue and pain. Although pain was not covered, but the headache was seen 70%, bowel syndrome, bladder problems. So these patients are not only coming to neurologists, they're going to cardiologists, rheumatologists, fibromyalgia, and this is a huge overlap. So every part of the medical stream, we're seeing this. And neurosurgeons seeing it as MRI negative corticovenous syndromes. So everywhere we're seeing them, but they are possibly not being diagnosed early enough. So, and not being explained enough is this issue. So this is another slide just to show how difficult for the ordinary people to interpret the symptoms. There's a beautiful paper by McWhirter. They studied what the people mean by brain fog. So brain fog is a common presenting symptom with this group of patients. But if you look carefully, some people's mean brain fog is a dissociative experiences, depersonalization. For some it is forgetfulness, for some poor concentration ability, for some it is fatigue, for some it is dizziness. So unless you go deeper in the symptom and questioning the symptoms, this is the main issue when these people gets moved around. Nobody really knows what's happening. So rather than labeling it, so this is very important for the clinician. The history taking is very important to understand what's going on. Now we know the construct that is involved. So there's a huge body of literature. I'm not going to review it here. So the papers, the IBEC paper and the other reference paper I'm quoting with the interest people can go and read. So there's it's overlap with agency, bodily awareness, interoception, sensory motor function, emotion processing, salience, and emotion dysregulation. Overall, the broader picture or the prediction and inference, the more something gets people focus on it, it gets worse on that. So it is a predictive thing. It gets worse and worse. So this is something keeps on happening and overlap with all these cognitive and psychological constructs over it. If you look carefully, there are other overlapping neural network which also come in play. Again, there's a huge body of literature. Now I'm not going to in depth here, but you can look into this detail. IBEC did a very good representation. The major networks involved is sensory motor and TPJ network, the salience network, the limbic network, the dorsal attentional network, and also the cognitive control and the motor planning network. And in different studies, depending on how they studied the methodology, the study protocol, the fMRI protocol, there's overlap and often different findings. There is some heterogeneity in the findings, but overlap, they give a broader picture. This is another study from IBEC group. They find out one of the key issues which you often discuss regarding the relation of the stress. So, I mean, Team's paper in 2011, it is a beautiful paper, showed that when the self-report, stress is not often identified. So this is clarified in a recent paper, whether it's a state or it's a trait. So this study published in Brain, they look both at the cortisol, salivary cortisol level and also the neuroimaging level. When they're done together, they found these people have low salivary cortisol, the healthy controls in the early morning. On the other hand, there is an atrophy of their parahippocampal and the limbic area going on. So this is a more of a trait that later comes to a state. So this is an ongoing controversy. There's a trait or state. So I think it's resolved now, and stress remains an important factor in this group, but not the way that we understand. It is not straightforward. So this is another beautiful paper, which we can see how it goes ahead. So this is a called 2 or 3 hit hypothesis. So there's a moderate biological risk. There's a moderate childhood maltreatment, which is always important in the Weber paper as well. And if there's a moderate precipitating stressor, it tips over the symptomatology to a diagnosis of FND. Now, someone has a severe biological risk with a tiny mild precipitating factor, they can tip over. And so these predisposing factors work by biological factors, and so precipitating factors work by the stress pathway, and they act together. So similarly, you can someone have otherwise normal but a massive severe precipitating stressor, they can tip. I think this is most commonly embodied in during the First World War, when we see the evolution of the shell shock, where people get more aware of it. This is a classical example. Otherwise, normal background and everything, sudden severe precipitating stressor, people go and developing functional symptoms. So the other thing that is that we know it also fits in the structure of vulnerability factors, triggering factors, and the maintaining or aggravating factors, the other construct of the persistent somatic symptoms, the PSS. And the similar things we can see in FND as well. So there can be pathophysiological precipitating factors, can be limb injury, drug side effects. We often see people waking up after surgery with a paralysis or functional motor disorder. And there are psychophysiological like panic attack, dissociation, and there are predisposing factors like pain syndromes, fibromyalgia, and migraine is very well known to be associated with this group. And there's another group, hypermobility. Again, Selma Aybeck, the group published a very recent, beautiful paper, how this thing is a predisposing factor. So all this predisposing factor changes the top-down increases the top-down prediction error combined with the ongoing precipitating factor, and they precipitate the functional neurological disorder. And some of them may perpetuate it, like the diagnostic uncertainty. This is a big issue. Misdiagnosis, another condition, poor communication, lack of treatment, and people don't get the confidence about the diagnosis, and it perpetuates it. Now, this is the issue we'll be focusing. If we can get them early, can diagnose them early, give them the diagnosis early, and clarify the diagnosis, we may revert this prediction error much earlier. So together, all this complex picture give rise to the complex picture of functional neurological disorder. Now, this is the need. This is Professor Mark Edwards' group have proposed very nicely what we need to do. This is a step up from the previous Scottish model produced by Johnstone. So stepped care model. So this is how a patient should be ideally managed. The patient will have referral from the GP, the neurologist will see, there should be good primary care management, and there will be physiotherapy. The patient can refer themselves, and there will be smooth transitions between everything. But this is an idealized picture, and this is what we get. This is the reality. This is the FND Hope study. People feel like they have been stigma related to the diagnosis. They feel they're dismissed. And the diagnostic level has an impact because nobody explained them. They feel they're being fobbed off. So this is the very real thing. And in this scenario, in my nascent service delivery, with only one neurologist looking after the entire group and sorting out how to give them the support, I need a solution. And this is an acute problem everywhere. We need a solution, how to do about this. We know some things work, but there's a huge service provision issue. So one of the things, because my background in stroke, this paper struck me. So this paper by Sannal et al., they looked into what they call functional stroke. Actually, majority of the patients presenting very acutely as stroke, but most of them had what we know as now functional motor disorder or functional speech problem, some people with functional sensory symptoms. And Dr. Sannal is an expert hypnotherapist. So because they work in a stroke group, immediately they diagnose, scan normal, symptoms ongoing, give them a diagnosis of functional neurological disorder, and they immediately put the patient under hypnosis. And their outcome is great. You can see how beautifully they've reduced their NIHSS score and also the MRS. And in the follow-up, they've seen 86% remain well at 6 months. and they do a nice cost calculation, and the average cost saving of 1,650 per patient. So the patients are not going home early, they're remaining stable, they're not coming back to the service. So this is something we need to do. So this allowed me. Previously, I was not much worried about hypnosis. I knew it was there, but never bothered to study it. So since then, I'm a keen student of hypnosis. Okay, so then started my journey about hypnosis. So hypnosis, again, is a big construct. There are many concepts, psychological construct going on. What is hypnosis? Is it a top-down or bottom-up thing? There are a lot of cognitive constructs. I think Devin is here. He has done a magnificent paper. I've quoted it here. If you want to know what the current construct, psychological construct hypnosis is, very welcome to look at these 3 papers. But practically, it is a process in one person gives suggestions to another person for imaginative experience involving alteration in perception, memory, or action. And usually it is given after an initial set of suggestions for the subject to enter a hypnotic state, or what we call a hypnotic induction, state of relaxation or concentration. After that, they're given some suggestions. Now it comes in many flavors. So the main are the traditional hypnosis, whether we give direct suggestions, or the Ericksonian hypnosis of the indirect suggestions. Now there's another group, self-hypnosis. Now we're not sure whether this group bring to, but overall this is the, in between them there are many other flavors, whether you are under hypnosis, you are doing relaxation or doing therapy, then it becomes hypnotherapy. Now there are again many flavors of hypnotherapy. On the other hand, there are other direct verbal suggestions that can be given without putting them into the induction or the relaxation phase. We call them direct verbal suggestions. The suggestions can also be given after administering a sedative drug referred to as abreaction, narcotherapy, or narcosuggestion. This was in vogue in 60s and 70s, and we'll see it. I will see it. I'll show it later how effective it was. Quite effective actually, and what we can do about it. So this is in brief. So hypnosis involves absorption, a tendency to fully involve in a perceptual, imaginative, and additional experience. The dissociation, or the mental separation of the components of experience that would ordinarily be processed together, and also suggestibility, responsiveness to societal cues linked to an enhanced tendency to comply with the hypnotic instruction, representing a suspension of the critical part of the brain. So these 3 parts mainly component of the psychological construct of hypnosis. Again, in them, how to study, what are the process involved with it. There's a huge body of literature to it. I'm not reviewing it here. The Spiegel 1991 paper and Tarhune 2017 paper are very good. You can go through it. Now, hypnosis is when Charcot used it quite extensively, but it has its own rise and fall. But the first person possibly to use hypnosis was Russell Reynolds. If you look at the hypnosis, this country played a big role in its development in the first part. And Charcot was very clear about the concept of the functional neurological disorder, and he used hypnosis much to its detriment. Like he used to have those, what you call the Charcot ladies, they were kind of showcased, which is unthinkable now. And hypnosis were used, and some of them improved, or some of them used for showcase. Now, this feeling to distribute in the later on after Charcot left and Freud and the other people, there is a disconcerted regarding hypnosis. So one of the common thing in the hypnotherapy group, they say Freud didn't like it because he was a poor hypnotherapist. It's a common joke goes on. So it fails into disrepute. There's one patient claimed to be shot, one of the neurologists while under hypnosis, and it was stopped in Salpêtre at that time. So this is how the story goes. And it went into disrepute. It is again making a comeback since 60s. A lot of studies, Spiegel in US, Oakley Cannon, and the other people, and they're doing a lot of work, and hypnosis is making a comeback. So I'll briefly look how hypnosis works. So one of the key things of the hypnosis, the strongest, is the suggestibility in people with FND is higher. Now, if you look at the general people, the suggestibility scores between 10 to 15% of the general population. In the FND cohort, it's higher, but not as high as other dissociative conditions. They possibly had higher score. So this is again the beautiful paper by Wader et al. That did a systematic review and shows. And again, the people with functional neurological disorder has a higher suggestibility. Now, this is a chicken or egg situation. We really do not know whether this is because they have the higher suggestibility, they are prone to FND, or because of the FND, they have higher suggestibility. Anyway, suggestibility higher, so the use of hypnosis as a tool remains stronger. Now, this is one of the first papers which shows how hypnosis can be used. So Marshall et al. In a patient with functional left leg weakness show a series of studies. Actually, they've done a series of studies later. They shown when the people is trying to move the left leg, which is hypnotic, the right cingulate and the right medial orbitofrontal cortex is lighting up. In a later patient was given hypnosis and produced the hypnotic paralysis of the left leg. The similar pattern showed up. This is very interesting. So hypnosis is mimicking a pattern that is seen in people with functional neurological disorder. So what happens during hypnosis? Again, there's a huge body of work. Again, I'm just summarizing it. This I have summarized for my own use. I'm sharing it here. So you can find big gaps in it, but that's how I understand it. So first thing is the subject relax and focus. The induction phase, there is reduced activity in the dorsal anterior cingulate. And there is later on, there is more decreased connectivity between the dorsolateral prefrontal cortex and the default mode network, and the brain is more receptive to suggestion. And then later on, there is increased connectivity between the dorsolateral PFC and the insula, and the brain puts the suggestion to the work. This is the main thing or the big summary how things work, but there are more complexity. It is more nuanced depending on how study methods are used and other things. Now, on the other hand, let's see what happens in FND. So this is again a beautiful paper from Ibex group 2024. They've seen in this group of patients, the same group they used for study in the stress paper, the same patient group they used with functional MRI. They found when compared between this group, the salience network and the limbic network, the connection was significantly increased between the salience network and the limbic network, and the salience network and the default mode network, predominantly between the insula, and the executive control network and the default mode network. So this has been seen earlier with the other fMRI research as well, task-dependent and resting state connectivity. Now, it was decreased connectivity between the limbic network and the deep network, and the central visual network, and the salience network, and also between the visual network and the somatomotor network. Now, this is our ongoing work I'm doing with our students. Siddharth is here. So we have seen in the early phases, actually hypnosis, if you look at the group level activity, it's opposite action compared to the action seen in FND. It reduces the connectivity between the salience network and the limbic network, and specifically the executive control network and the default mode network. This was shown in the Jiang paper, but not shown in the earlier McMillan paper, but this is currently being seen. And also, this is seen everywhere. There's increased connectivity between the visual network, somatomotor network, the salience network, and the temporoparietal network. So hypnosis, in a way, when we give it, it is counteracting the changes that are seen in people in functional neurological disorder. So our work is ongoing. It is quite rigorous because the data is variable and there's some variability we're going to adjust for it. So hopefully we'll be able to show in a more proper way rather than qualitative way how these changes are happening. Now coming to the most important review that has come up recently, again, Quinton Dealey, one of the people here, and David Oakley, and Kanan, they found out, there have been a beautiful literature review, and they found out how hypnosis is effective. Especially, I recommend that you go and read this paper, freely available. There's two study by Moine et al., very significant. So in the RCTs, again, there are variability in this group, so they could not do the meta-analysis. It is quite effective. And if you look at the RCT done by Moine et al., it was effective in the wait period, but not effective when compared to the standard physiotherapy. So we can say hypnosis is as good as our standard physiotherapy, and it can be first point if we do not have anything else. That I take away from this. So there are other studies which are uncontrolled, which is forward in this subject, and they did analysis later. And they found the usual efficacy usually goes up between 70 to 86%, usual for hypnosis or other forms of suggestions. But this is a very interesting graph from that literature review. This is available in the supplemental element, not in the article. But they have showed the studies non-hypnotic suggestions and the hypnosis, and both together, because non-hypnotic suggestion was involved earlier. And if you look carefully, their efficacy is stronger compared to hypnosis alone. We really do not know, and the John Stone's group published a paper, what they called a therapeutic sleep. Just use a propofol without any suggestion. It also has a similar efficacy rate. Anyway, they go higher up compared to standard therapy, between 70 to 80%. Now, how it is working? Most likely, they are basically changing the Bayesian bias. You know, there's a prediction error which gets worsened in people with FND. The more they go into it, the prediction errors get more distraught, and the more they go into the disease. Possibly the hypnosis working at multiple levels changes the bias in the brain. That's how things get better. So I borrowed the term from the psychedelic trial, the relaxed belief under psychedelic, or the reverse trial. I call it relaxed belief under hypnosis. So hypnosis works to relax the precision weighting of the pathologically overweighted priors by reducing the amygdala overactivity, and the increased sensitization of the high-level priors to bottom-up signaling because of the decoupling of the ECN and the other networks. And the heightened sensitivity via the salience enables the potential revision and de-weighting of the overweighted priors. Now, people in hypnotherapy will take the patients and visit them in a safe way to their prior beliefs or the prior events that precipitated it. And often their belief system gets changed. And possibly this is working, changing their belief system or their priors, which changes the bias for the function.
Oh, thank you. We're going to work this Sunday, yeah?
Yes.
Yes, from our school.
Right. Should I go on? Okay,
Yes, I've
so
muted
well
them
and
for
good.
you.
So far, well and good. But there are significant challenges for hypnosis to be implemented. And one of my aim is to start a proper hypnosis treatment arm under the NHS service. This is one of my goal to do it. So the challenges are many. The data, if you look carefully, they are not robust. So we need more trials, better trials with a larger number. The other thing is the variability, what we should do. That whatever we do is enough, or we need to do a specific protocol that needs a broader discussion, and we can even say and try different methods, because all the patients are different and we need to change our hypnosis plan to the patient, what we do. So there comes the question, what we should do. And is hypnosis necessary? This or the suggestion is necessary, or should we be using the older successful therapy of so-called abreaction treatments, or just putting them under sleep? But again, we have seen in the other paper, and possibly that's why the Sannal paper is so successful, because they're seeing the patients as soon as possible, as early, because of the nature of the presentation. Possibly there is a time window when we need to do it as soon as possible, before the beliefs, the biases, and everything. So for me, some patient with functional motor disorder, going on a wheelchair, this produces a huge bias. Then giving him out of the wheelchair with obesity, of its chronic pain, of its fatigue, hypnosis is not enough. We need to combine it with other modalities to change the priors and the biases and everything. So the earlier we do it, the better. This is my opinion at this moment. And the other things are scripts and metaphors. Do we need some different scripts? Because there are a lot of, because the hypnosis is used by our pain fraternity, our anesthetist fraternity, they have very well developed scripts specific for pain. Now there's a beautiful study. There's a what we call magic glove metaphor, where the arm becomes numb. There's a study used in pediatric FND with arm weakness. They use that metaphor to improve the symptoms. So can we use some of these scripts which are effective? But again, we need to study a lot what's happening. For that, before that, we need to do a lot of more. We need to develop a group of hypnotherapists interested in FND. Only then we need to build up a critical mass. Only then we can do all these things. Then coming the old controversy, is the hypnotherapy, the person giving the suggestion, is important. Now, if you look at the history, possibly the pendulum has swung. For Mesmer, started with animal magnetism. It is everything with the person doing it. Then the change, it is everything with the person having the hypnosis, the transability skills, and possibly in between. There is some credit goes to the hypnotherapies because of the rapport and other things. So is there a way you can study it? So in our BISCA presentation, there's a nice slide is shown. It is, I think it's in Germany. They did the EEG for the hypnotherapists and the subject undergoing hypnosis. I do not think they have published it so far. It shows how synchronized the EEG has become. Maybe some people are better to empathize or establish rapport with them, so they're better at hypnotherapy. We don't know. But regarding the variability I have seen in some of my patients are already getting hypnotherapy with our hypnotherapist. I know who is a good hypnotherapist because my patients personally going in, they come back, they're feeling better. Maybe it is a person factor. It may not be how they do it or how they deal with the people. This is another clinical thing. The most important thing we need to address is the stigma of it. It's still there. And I think we're working with Tim and Albert Joseph and the Matt and the other group and Davin Quinton. We're planning to do a broader survey. We'll hear about more soon in what people are using for hypnotherapy, for the patients and the clinicians, what they think about the process. What are the bottlenecks? Why they're not, like one of the patients, I suggested hypnotherapy, okay, you can use hypnotherapy. The patient told me very clearly, no, I do not want to lose my mind. I do not want to take someone control of my mind. I tried to pacify her, but yeah, she was that idea because she had gone somewhere on and there was a stage hypnotist and possibly he was turning people into chickens or something. So it gives a strong stigma. So that's something we need to do about it. I need to tell people, okay, that all hypnosis is self-hypnosis. The stage hypnotists they've trained themselves to find out the highly hypnotizable people very quickly. Now, why I'm keen? Because for a clinician practicing FND, hypnosis has its own advantage. It's easy to teach. Now, there are certain group in NHS that teaching it to radiologists, radiographers. There's one group in Glasgow that using it to reduce claustrophobia. And again, they possibly not published their work. It is a kind of word of mouth in hypnosis circle that they have reduced significantly. They're saving around 150,000 pounds per month just for avoiding the claustrophobia. Otherwise, these people need to go to an open scanner, which costs 3 times the MRI scanning. Just by hypnosis, they're reducing claustrophobia and they're achieving it. And it is highly teachable and it is easy to acquire. And it is cheap and quick. You do not need any fancy thing. You just need a person who is willing to listen to you and possibly a quiet room. That's it. And it's quick. And the skill is transferable. You can give the patient something to work upon. Them after they give them a script or something to work upon, they can work on it. And the patient gets ownership of it. So for me, if we can handle the stigma and other issues, okay, so there are certain risks with hypnosis. Certain people, their dissociation can worsen. Some old traumatic memory can resurface, but there are ways to deal with it. Possibly you need to liaise with your psychiatry team more. And you can need to exclude people under actively in suicidal thoughts or a lot of like dissociative personality disorder, don't want to worsen their dissociation anymore. This group, and if you can select them properly, I feel this is an ideal NHS solution. But we need more data about it. So this is my point. So I will now share some of the research we are planning to do with my colleagues, one of kind of practical imaging biomarker for hypnosis. So one of my questions, because I come from a rehab background, so what dose is enough? We often discuss it in rehab. How much physiotherapy is enough? How do you know the patient is not participating? This is not an easy question to answer. Similar thing for hypnosis. How much is enough? How low is too low? So how do you know it? So there are a lot of data coming from fMRI literature, but fMRI is costly. fMRI is not easy to do in clinical population, but there is a poor brother, a poor cousin of fMRI, which you can do called functional near infrared spectroscopy. So this is something you can wear on your head. It sends some light to the scalp and comes back, and then you record it. And because this light is an infrared spectrum, it can go through and through of our skull. So and this creates an optical window. And it comes back reflected, and while it is the light source, it is coming back, you can detect it, and then it penetrates not much, only the top 5 centimeters something of our cortex, but you can detect what's going on there. You can get a signal of the oxygenation, oxyhemoglobin, also the transfer quotient. So you can get a kind of bold signal or blood oxygen level dependent signal similar to fMRI, but it has other advantages. You also pick up signals from the surrounding metabolic things, surrounding blood vessels, blood vascular tone. So these are the advantages, and this field is rapidly evolving. And it is getting more cheaper and cheaper. Hardware is easily available, easy for field work, portable. People can wear it while doing it, and I call it performance fMRI, or maybe more advantages than fMRI. This is a person who is here. If you have any questions, you can ask him. My colleague, Dr. Datta, is in Birmingham. So next few slides are actually from him. So recently, we're trying to use it during this finding the depth of hypnosis. But again, controversy goes on what depth is. But MAG1, this classic study in 2009 and 2015 showed that depth can be measured. And there's a one group feels it is important, some group feels like induction that it may not be that necessary. The suggestion is enough. But I would say the jury is divided. So we're trying to identify, because depth can be measured and is predominantly prefrontal. So trying to identify if we can capture it with a single source FND. So recently we had a meeting at with the ENCODE group, University of Birmingham. You can group. There's a group hypnosis session going on. I'm not seen here, but I was doing the hypnotic. There's another person relaxing and wearing it. Another self-hypnosis going on, and we can recording, and we can record the signals from a single pole and see the variability and the reading up. So we have had we had collected few data, preliminary data from some patients, and we can see the oscillatory modes as they go deeper and deeper into the hypnosis, it goes down. I really don't understand the mathematical part of it. Maybe if you're interested, anyone can explain it later. What the signals mean and other thing. So this is something we're planning to do in addition to some of our future research to find out what hypnosis. We feel that it will make hypnosis more approachable, more quantifiable, and we can generate more data to bring it to the service more and more. So thank you for all your support, and thanks for the group I'm working with, and thank you for my group members at BISCA for teaching me hypnosis, and they're very helpful. Thank you. I think we have some time left for the discussion.
Thanks, Abhijit. A great talk through a very broad and long literature, and yeah, and a particular thanks for stepping in at the last minute to give us this talk. We've got lots of people online and a lot in the audience, which speaks to, I think, how interesting this topic is. Both, hypnosis is interesting and FND is interesting, and there's always been this historical overlap since Charcot, particularly, and it's sort of interesting to reflect on why it's gone away from the public consciousness or from treatment. And it's, I think it's going to be, it's so weird. We've been sitting on this effective tool for, I think, potentially for a very long time with this disorder, and perhaps it speaks to that if something isn't new or fancy, then it must be, it's not very good. It must be something novel that works, and throwing the baby out with the bathwater when we're rejecting previous clinicians who have obviously done a lot of work and have a lot of expertise, particularly Charcot, obviously. So yeah, fantastic. I'm sure. I think we've got one question from Jacob, which slightly Jacob Bird. I don't know if you want to unmute and put your camera on and ask your question. If not, I can read it out, which is a bit about the stigma and other aspects of the mechanism potentially going on here as well.
He has no microphone.
Oh, he doesn't, Jacob. So I'll read out your question. So is there a particular factor separate to working through the fear nidus which makes hypnosis better than focused psychotherapy, EMDR, etc.? If so, how would you destigmatize a Cinderella treatment such as hypnosis for an already stigmatized and therefore potentially Cinderella neuropsychiatric disorder without compounding the situations for both?
This is a very important question, and possibly this is a kind of what we call Rosetta Stone question, but I do not have the answer. What I can tell you, possibly because hypnosis, the hypnosis approaches the topic. Tim, can you mute some of the mics?
Oh, I can't hear much this end. I don't. It seems all right.
You mute.
Okay. Yeah. So because the hypnosis, it takes, we call them double dissociation techniques. We can take the people further away from the memory and other things, and they can be used more. But again, I think the jury is out. We really do not know which one is more effective, whether it is EMDR and the other thing. And if you look carefully at the hypnotherapy scripts, and one of the hypnotherapy book actually tells what CBT and DBT developed, they brought away from hypnosis. So they have using the hypnotherapy techniques used in the past. So they're very similar. So this is something I show in my slides. This is often asked, what is the common between hypnosis and meditation? So this is one of the reviews came up recently regarding mindfulness, meditation, and hypnosis. So if you look carefully, some of the meditation techniques are very similar. And one of the older yoga technique where there's an eye movement called Trataka, where they use the eyes to be turned upwards, and it is very similar to eye roll technique used in hypnosis. And the other breathing tools used in traditional meditation are very similar to breathing-based meditations, and they're very common. So if you can say there is a lot of overlap between the network activates during the hypnosis and the network activates during the mindfulness meditation. But what they separate, then comes what the suggestions that we give or the metaphors that we use, they divide themselves between them. So again, I think the ideal situation would be what the patient clinical subtype is, what are the factors, what are the more important things. Like if you look at this, we're discussing during the last meeting, if you look at the desensitization technique used for phobia, similarly, there are stronger tools available in hypnosis for phobia. But possibly, but again, there's a so variability in this thing and do not have a randomized controlled trial, but possibly hypnosis in certain group of population attains phobia relief much faster because the way it does it. So this is an understanding, but we do not have any data to say it. But I understand this is a very important question, and this is the way we should go forward. We need to try which one is useful, which one is more useful. And the answer possibly comes to regarding the patient subtype and what kind of network or the other factors that are involved. And I have found some FND patients when advised for meditation, they can do it. And the other practical question is, say for my trust, we do not have any psychotherapist. It's a very simple answer for me, which is the reality.
Great, thank you. So I guess on a simplistic level, perhaps also you're going straight to the symptoms rather than via whatever might have precipitated them in the first place. So I see Matt's got his hand up. I'm wondering if he's going to comment on the REBA hypothesis, which for those in the room, I put it in the chat, but this is the rebus hypothesis of Carhart, Harris and Friston for psychedelic action. So which is your, I don't think you quite had the time to mention the interesting background to that. But Matt, I'm not sure if you're commenting on that or something else, but far ahead.
No, absolutely spot on, Tim. Yeah, thanks for the talk, Abhijit. Yeah, a bit of a predictable question for me, I suppose. And definitely something you alluded to in the talk and that we've had conversations about before, but just thinking about kind of the mechanisms behind hypnosis and its applicability to FND, sort of in comparison and contrast to other interventions that we've talked about. So abreaction you mentioned, but also ketamine. I think you've done some great work with that. And the kind of rebus model is something that I might use to think about why we might want to use psychedelics in FND. So are all these things coming at the symptoms the same way in terms of reducing top-down kind of prediction errors? Is there something different about them, do you think, particularly in terms of hypnosis? Is it coming at the symptoms from a different way, or ultimately are we getting to the same place via different mechanisms, if that makes sense?
No, I think there's certain. So this is another very important question. So if you look at the history of evolution, there is something called concentric evolution. Like there's a species of crabs, although they look same, they possibly evolved 3 different ways in the evolution. So because we are targeting the same set of network, we may be using different tools, but at the same level, they're working through the same network. But again, psychedelic will be different. Because if you look at the psychedelic literature, the dissociation property and the sensory network effect is completely different. Again, all psychedelics are different. LSD is different, psilocybin is different, and ketamine is different. So I think it will boil down to the question, what are the problems we're trying to solve? So the more go into detail and more we identify the network. So for me, again, FND is a heterogeneous group. If you look carefully, people with focal motor disorder and the functional seizures, they're possibly the biggest chunks. Although there are certain overlaps, there's the biggest chunks that go around, and some of the symptoms are different. And I think Susanna is here and she's doing some remarkable work. So possibly we'll find answer from her study, how they're different and whether they're different and the outcomes are different or something like that. So in general, people possibly with functional seizures, they have in my opinion, a bit worse outcome. And on the other hand, if you look at the hypnotic scripts used, possibly hypnosis is most effective for people with motor disorder. It can produce significant and dramatic effect compared to the other things. So, but again, these are, we understand that is going to happen, but we do not have a definitive idea. Only thing we need to do more study and we can give the answers to these questions. But yeah, so if you look at, when hypnosis and meditation comes, I think we are going into this condition, what we call non-ordinary state of consciousness, NOSC. This is evolving another big field of research. So it calls psychedelics is one of the meditation, hypnosis, and trance. There's one group in France, Corinne Sombern-Lay, they're doing a lot of work in trance. And if you look carefully, trance therapy, trance-based thing, or the shamanic trance, has been used. And I think Harish is there from India. So in India, a lot of functional symptoms are treated by the shamans. The people have been taken to them, they're cured, or the religious leaders. Possibly they're using some trance phenomena there. And the trance phenomena they're studying. Some part of the time, in the default mode network, they're different, but again, they dissociate. The network pattern changes completely and different in trance. And it is again different from psychedelic. So there's some overlap between psychedelic use, hypnosis, trance meditation. There'll be common factor, but finally they'll be different. Now we need to find out which patient profile will sit into this thing and then choose the appropriate treatment for him. But the more we have, the more better, just like a migraine treatment. So the wider our armamentarium is, the better we are. Some patients may not tolerate amitriptyline and some patients may not benefit from everything. We have CGRP antagonist for them. That's it. The better, the more that we have, the merrier we are as neurologists.
Thank you, Abhijit. So yeah, just when you're on the topic of shamans and moving into the sort of religious or cultural figures, I guess the current form of that is the sort of alternative practitioners and quacks who obviously treat symptoms effectively through this mechanism without knowing it. And it's the basis of a whole massive industry. And and it's always sort of strange thinking that it works, but it's not working the way people think it is. They're just giving a pseudoscientific explanation and manipulating expectation that way. But and of course that's the sort of placebo effect writ large, and all, you know, wherever it works, it's working largely on a functional component or a proportion of symptoms that are related to that, or even the whole thing, as we know in FND. Great. So I've got a Niraj, I don't know if you want to put your camera and mic on.
Hi, thanks, Tim. Thank you, Abhijit, for excellent talk. I've got two questions. One is about mechanism of action. So you seem to suggest that suggestion is the main mechanism of action. I don't know whether Norman is there. Norman and I did systematic review of abreaction, and there are several mechanisms. Abreaction as Freudian mechanism plus suggestion plus exploration plus a little bit of rehabilitation process. So do you think is suggestion the main process? And secondly, as we've already alluded to, and Tim was mentioning about placebo, because I think there's huge placebo effect in FND, and any new treatment, anything fancy, anything slightly out of ordinary would normally have initial very significant positive effect, and then it starts to reduce. So what are your views about those two issues?
Yeah, no, thank you. Excellent questions. The first thing I'll just clarify, I think possibly it was not the way I put it forward. I do not think suggestion is the only action. There are all other actions are going on, because if you look at the hypnotic metaphors and other things, the memory and the other things are involved, and the top down and the bottom up, everything is being involved. So my position is that because there's a heterogeneity in the literature, frankly speaking, part of them are action, but we really do not know what is the key part, maybe altogether. And maybe depending on the person who is taking the hypnosis, the person factor is very important. So I'm open to understand what's happening. Possibly we have not yet reached the state we can say very clearly, okay, this is the action. Just for hypnosis, again, there's a controversy, how it works, how top down, bottom up, or the other internal states and hypnotizability. So my construct is that as a clinician, we really do not know. Whatever work, we'll explore it, and that's it. Now, coming to the placebo, I feel, again, it works through the correction of the Bayesian bias system and everything, and I strongly recommend it. I'll just tell you a story. We had one patient seen in our Preston system, seen by many of the colleagues. Now she's in my FND clinic. She's a clear-cut diagnosis of functional neurological disorder, and one of her symptoms are disordered breathing. Kind of a lot of somatic symptoms go on. So once upon a time, she went to a new neurologist who suspected her to be myasthenia gravis, and she was given a tiny dose of pyridostigmine. And since then, last 10 years, she has the idea she has myasthenia gravis. Now, she has accepted the diagnosis of FND, but sometimes the concept of myasthenia goes up, sometimes she feels I'm FND. Now, whenever she has any URT or something, the myasthenia part goes up. And she kind of, other times she can go without pyridostigmine, but she has been extremely investigated, no evidence of myasthenia. Recently, she had one bout of URTI. She was the GP, she moved to a new area, the GP was not willing to give her the pyridostigmine. I told her very clearly, this is the letter I wrote. I clearly documented that pyridostigmine is possibly working through placebo, and let her give her a tiny dose of pyridostigmine, because whatever is happening, her distress is real. So if pyridostigmine working through placebo stops the distress, I'm happy with it. So even if it is working through placebo, I'm happy. But I would say, rather than placebo, hypnosis has a long track record, and the other thing, and the evidence to the neuroimaging, this is strictly counteracting the changes that are going into FND. And even if the placebo, it should not have a long lasting. So if you look at the other trials, the group of people who respond, they have a long lasting relief. It should not happen in placebo.
Thank you.
Great, thanks, Abhijit. I was just typing a final response to Osman, and I don't know if Osman's the Osman, I think it is, but a child psychiatrist at the Evelina, but if he's able to ask his question. In the meantime, Abhijit, people have asked if any protocols you have or know aware of, if you could put them in the chat, and if anyone or anyone else online has got those protocols for, obviously nobody's really worked out how best to do it, but they've worked their own way.
So I think it will depend on the symptoms they're presenting with. Like there's a group in Holland that using the arm catalepsy technique to show with people with functional tremor. They're using arm catalepsy to make it stiff and then demonstrate it can be made stiff. And they published a paper in 2024 January. The review came up, and they're quite successful. Again, there's a case report of using this magic glove technique to use some pain and something. What I'm interested, this possibly I will study called part therapy in hypnosis. So when you tell people, okay, one part of your brain is willing to get better, the other part may not be willing. So there's a kind of a gestalt psychotherapy-based technique where people bring their unconscious thing together and sort things out. So that might be useful on some of them. But yeah, this is another open area. We really do not know. And this is something we'll be working together, other interested people in this group, to develop what scripts to work on. This is something we need.
Sorry, everybody. I've been presumably been typing everyone's head sort of clunky keys as I've been doing that. I didn't realise how sensitive the microphone is to this. Anyhow, so thank you, Abhijit. So there are. I don't know if Osman's there to ask a question. If so, but if not, I'll just tidy up a couple of other loose ends of some interesting questions about dissociation.
Yes, I'm here. Yes, hi. Just a very quick question about because sometimes we use hypnosis formally, sometimes informally in children with FND, and we find sometimes that they recover, they have effective response to the functional symptom, but then sometimes they go on to develop other symptoms later on. So we use the term fetal conversion. So the legs, yes, they start walking, they're out of the wheelchair, but 2 weeks later they've developed tummy ache, or 6 weeks later they're fainting, or they've developed tremor or something. And not to say this means it shouldn't be used, but so there's obviously you might not have information, but it was just sort of, do you see this, or do you have any information on this, that that it is effective sometimes for a specific symptom, but perhaps there's other issues. I don't know, but do you see this sort of stuff, that it helps and then something else emerges?
No, actually, this pattern, although may not be this fast in adults, we commonly see in adults. There's a group of patients who keep on multiple symptoms over the time, and they have sometimes an addition to fatigue, which is and pain, which is the background story, goes on fluctuating, and that some people do have many symptoms develop. So I understand pediatric FND is another different ballgame, because maybe their brain networks are hyperactive or something immature, overlap is not clear. So I understand pediatric FND, other thing. So in anyone developing this symptom, so what my mind asks to a psychiatrist, is there any issue that we have not uncovered? Or is there any trauma or other issues that we have not uncovered that needs addressal? So in that issue, if the brain is repeatedly developing the symptoms, we need to go dig deeper and ask the question. So this comes a typical good neuropsychiatric practice to sit with the patient and find what's going on. I think that is the most plausible answer. But I'm very open. I think hypnosis is not a single solution. Functional neurological disorder is a multi-brain network disorder. And if anything affecting multiple brain networks, we need to address it in a multiple way. Someone having a weakness, gone into a wheelchair, hypnosis, if the legs is gone weak, the legs is diseased, the muscles are weak, only with hypnosis you cannot make them walk. Okay, with hypnosis, you can bring some voluntariness back to it, but in addition to it, you need physiotherapy and occupational therapy tools. Hypnosis is not the solution, only solution. It is a part of the solution, maybe a strong part of the solution.
Great, thank you. So we're just coming up, well, just a few minutes over, so we'll wrap up. But just to comment on that I think it's not unique to hypnosis. Perhaps you see it more because it has such a dramatic effect that you might notice the popping up of symptoms somewhere else and think that it might be related. But I think it's any way you improve symptoms, yet there's still something generating symptoms. And I think, as you said, Abhijit, that's correct about, there's obviously, you've got to turn the tap off to symptom production, but whatever's going on underneath that, but you might better. But I don't know whether you could introduce suggestions of complete recovery, or of, or what are the limits of what we can do with this. But I think it just shows we need an overall approach, and as always, a sort of bespoke treatment for the individual and their individual circumstances. So perfect. So thank you so much, Abhijit.